So let's go ahead and get started. I am going to give you an official welcome. Welcome, everyone. I'm so thrilled you are here. I'm Janet Church, and I'm the new president and CEO of the Sjgrens Foundation. And I just am so fortunate to be joining you in this new role. Tonight's program is all about learning current information on COVID-19, the vaccinations, and the impact of both of those on our Sjogrens community. But before we dive in, I do want to share a little bit about myself since I'm definitely new and how honored I am to be leading the foundation. Many of you are familiar with me as a board of directors member for the past 8 years and the chair of the board the last 3, or perhaps you heard me speak at a national patient conference or on one of our town halls even this past spring. But if this is the first time that you're meeting me, I want you to know that I too am a Sjogrens patient. I also want to share a little bit about my background because it's important that you know my business background as well. My career has been spent primarily in the tech industry, and I bring my background in leading service businesses to the foundation. I also bring in other nonprofit experience to the table. And you can be assured that I will apply my business acumen to running the organization, and I will always lead with the foundation with the patient voice close to my heart. We all know and love Stephen Taylor, and Stephen and I worked together for a long time, and I consider this change in leadership to be more like a passing of a baton in a long distance race. So as Steve begins his leadership role at the Arthritis Foundation, I'm taking the baton, keeping our vision and mission wholly in mind as we move into this next exciting chapter for our Sjogrens community. So much is on the horizon, and I'm so thrilled to be taking us into the future. Now let's jump into our program. COVID-19, vaccinations, and the impact of both of these on Sjogrens patients has been top of mind for me and for the staff at the foundation. And we wanted to quickly bring you some updated information. So tonight we have Dr. Cassandra Calabrese presenting, and Kathy Hammett, our VP of Scientific and Medical Affairs, taking us through a Q&A process. As I mentioned earlier, almost 700 people registered for tonight's presentation, and more than half of you submitted questions on the patient poll. So Kathy and Matt Macara, our Director of Scientific and Medical Affairs, called over 400 questions that you all submitted. And we pulled out the most common and the most interesting to answer for you tonight. And those questions are going to be answered throughout Dr. Calabrese's presentation, as well as a Q&A time at the end of the presentation. Additionally, we initiated a patient poll with this program so we can see who has had COVID, taken vaccines, and the effect of all of these on our community. So let's take a look at that data now. Ben, could you bring up the first slide? 378 people responded to the patient poll about COVID and vaccinations. And out of this group of patients, the second slide, Ben, 6% of you have had COVID-19. For those who have had it, 79% had mild or moderate symptoms, and only 21% of you had severe symptoms. Next slide, Ben. 275 of you have had the first dose of the vaccine, with 50% receiving Pfizer, 47% Moderna, and 3% Johnson & Johnson for the single dose. 87% of you experienced mild or no symptoms, and 11% moderate. This leaves only 2% of the group that had a severe reaction to the first vaccine. On our next slide, 170 of you have already received your second dose of the vaccine. This was, of course, Moderna or Pfizer. And with 63% of you experiencing no or mild symptoms and 30% a moderate reaction. For those who experienced symptoms, the symptoms lasted for 48 hours or less for 76% of the respondents, with 24% of you having symptoms last over 48 hours. And then finally, of all respondents, 22% of you are still waiting to start your vaccination process. And a good 70% you have started, you either gotten your first or your first and second dose. But there are 8% of you who still feel you do not want to get the vaccine. So I think tonight's presentation delivers the information you need to continue making the best health decisions for yourself. And now I turn it over to Kathy Hammett to continue with our presentation. Kathy.
Yes, hi, thanks so much, Janet. So I am delighted today to be able to introduce all of you to Dr. Cassandra Calabrese. We've been really fortunate to have her expertise on our foundation's Sjogrens and COVID-19 vaccination committee. When we learned that the first vaccinations were about to become available, we knew all of you would have a lot of questions. So we formed a committee made up of top Sjogrens, infectious disease, and vaccination experts to answer your questions. And after a lot of analysis and discussion, the committee created a statement recommending the vaccination for all Sjogren's patients and started us off with a series of Q&As. So Dr. Calabrese also served on the American College of Rheumatology COVID-19 vaccine clinical guidance team. So she not only brings knowledge about Sjogren's, but overlapping related diseases as well. So Dr. Calabrese holds joint appointments in rheumatology and infectious disease at the Cleveland Clinic. She specializes in infections in the setting of immunosuppressive treatment for rheumatic diseases and rheumatic manifestations of infectious diseases. And she has a particular interest in infection prevention and immunizations. So we are incredibly honored to have Dr. Calabrese with us tonight. Dr. Calabrese, you can take it away.
Thank you, Kathy, so much. And thank you to Janet and the Sjogrens Foundation. And I'm just honored to be here and think this is a wonderful event that you're having. And as Kathy mentioned, as I try and share my screen here, I think you can see my presentation mode. Wonderful. I have a great passion for immunizations and infection prevention in patients with rheumatic diseases, including Sjogren's. And I have take great care and time to go over immunizations with my patients at every visit. And I think it's really important both to make sure patients are up to date with immunizations in general, and also to talk about fears and reasons for patients to be hesitant to get any kind of vaccine, and including COVID vaccine. I think it's really, really important to pause and hear those concerns and discuss patients' fears and concerns, because there's a lot of information out there, in particular pertaining to the COVID vaccines, and sometimes it's hard to know what to listen to. So in the next 15 to 20 minutes, I hope to cover some high yield topics and frequently asked questions, both about COVID-19, the infection in patients with Sjogren's, as well as COVID-19 vaccine in patients with Sjogren's. So to start, I wanted to highlight this slide. And if the COVID-19 Global Rheumatology Alliance is not something you've come across yet, it's really cool and really important, and been a wonderful source of information throughout the pandemic. So I wanted to share this with you. This was an idea that was born out of a tweet back in March of 2020 that, hey, wouldn't it be interesting to collect data on patients with rheumatic diseases who are getting COVID-19. So almost overnight, within a week, this international database was created that's run out of UCSF, and rheumatology providers from all over the world enter patient data into this website about our rheumatic disease patients who have COVID-19. So this at present is the largest source of information where we have learned about patients with immune-mediated diseases like Sjogren's who have developed COVID-19. So far, over like 10,000 patients have been entered into this database, many from my institution, the Cleveland Clinic, because the one main question everyone wants to know is, how do patients with immune-mediated diseases like Sjogren's fare with COVID-19? And does having a disease like Sjogren's mean you're more likely to get COVID-19? Does it mean you're more likely to do poorly with COVID-19? What have we learned about this? And the short answer is we're really still learning, and that most studies actually so far have shown that patients with immune-mediated diseases like Sjogren's are actually not at increased risk of acquiring COVID just because they have Sjogren's. What we've really learned is that these traditional risk factors you've probably read about or seen on the news, cardiovascular disease, hypertension, obesity, older age, these are the risk factors for getting COVID-19, and seemingly not having a rheumatic disease like Sjogren's or rheumatoid arthritis. And there's not a whole lot of data that suggests that having a disease like Sjogren's or lupus or rheumatoid arthritis is associated with doing poorly with COVID-19, but from other registries and other studies and this COVID-19 Global Rheum Alliance, there are a few instances where rheumatic disease patients like Sjogren's patients may be at increased risk for doing poorly once they get COVID. And those are patients who are on treatment with rituximab infusions, or patients that are on prednisone at doses of 10 milligrams daily or higher at baseline. So at the time you get COVID, these studies have shown if you're on prednisone, that might be associated with, hospitalization or not doing great. We got these wonderful questions that were emailed from all of you listening. And one of them, several of you asked about Plaquenil or hydroxychloroquine, and does this have any effect on COVID risk or protect you from COVID? And the Plaquenil story since the pandemic began last 2020 has really been up and down and confusing. And early on, it seemed like it might be the panacea to COVID, but after many studies, we have learned that Plaquenil, being on Plaquenil for a rheumatic disease or being started on Plaquenil if you were exposed to COVID or have COVID, has no association with protecting you from COVID or treating COVID or any benefit in any way. It also does not have any negative effect if you're on Plaquenil. You're not at more risk for having COVID or doing poorly from COVID. And that's a really good question because it has been confusing. This is a really nice study that I wanted to highlight, specifically looking at Sjogren's patients who developed COVID-19. And this was a study of 59 patients with Sjogren's who were infected with COVID. And they looked at the most common symptoms they presented with, which, as you can see, are pretty in line with what someone who wouldn't have Sjogren's would present with: lots of fever, cough, shortness of breath, aches and pains, and diarrhea. And what this study showed us is that Sjogren's patients seem to be similarly affected by COVID-19 compared to the general population in this study in terms of clinical presentation. And that, as I mentioned before, risk factors for doing poorly with COVID were not having Sjogren's per se, but having these comorbidities that we already know increase risk for not doing great with COVID: chronic lung disease, heart disease, obesity. So this kind of highlights what we've learned so far, that it's really these other non-rheumatic disease risk factors that portend a poor outcome from COVID, and not having a disease like Sjogren's or being on most of the medications for Sjogren's, with the exception of higher dose steroids and rituximab, as I mentioned. So to move on to the vaccine types, I always chuckle a bit now when I am talking about COVID to an audience, and that I made these slides a couple days ago and I already updated them. They have to be updated so frequently. It's like a water hose, the information and the new things we learn every day. But as of today, there are 3 currently available vaccines in the United States to prevent COVID-19. And these are the 2 mRNA vaccines from Pfizer and Moderna, and 1 adenovirus vectored vaccine from Johnson & Johnson. There are many other vaccines in phase 3, which is the final stage of clinical trials for vaccines being tested worldwide, and many candidates. And I expect by the end of this year, we will have a handful at least other COVID vaccines approved in the United States. And I'll highlight this on my last slide and here that the CDC website has wonderful up-to-date information for providers and patients, both on COVID-19 and the vaccines, and information about dosing and side effects and safety, and it's really, really wonderful resource. I like to show this slide to remind everyone that the COVID vaccines are safe. And of course, the slide is now outdated because I made it a couple of weeks ago when the Johnson & Johnson vaccine wasn't around, but this is what this slide is about. It's from the CDC website, most recent iteration of their review of safety data from the mRNA vaccines. And this was at a time now a couple months ago where many people had gotten both doses of the Pfizer vaccine and no one had yet gotten their second dose of the Moderna vaccine. And what this slide shows is that there were no surprises. The adverse events were in line with what we saw in the clinical trials. And as you all have either experienced yourself or heard from friends and family, that these vaccines cause what we call reactogenicity. So your immune response it revs up to make antibodies against COVID. And this can manifest as systemically fevers, chills, headaches, aches, etc., or locally with arm pain, swelling, and redness. And this is not something bad. This is not something that isn't supposed to happen. If this happens to you, this is your immune system doing what it's supposed to do. And these are common side effects, and they're actually more common after the second dose of the mRNA vaccines. And if any of you have ever had the shingles vaccine, Sjgrens, the reactogenicity profile from these two mRNA vaccines is very comparable. And for both the Sjgrens and the COVID mRNA vaccines, and now the Johnson & Johnson, I like to set expectations for patients that you might not feel great the night of or the day after your mRNA vaccine. I know I certainly didn't after my second dose, but these side effects, they're expected. They're a sign of your immune system doing what it's supposed to do, and they will resolve within 1 to 3 days. And then you should feel back to normal. So that's one reason for a lot of vaccine hesitancy, that people have heard their friends or family just felt not great and had a not great experience after this vaccine, but it's not something bad. It's your immune system doing its job. I borrowed this slide from my friend and colleague, Jack Cush, who put this together to compare. I'm just going to highlight the Pfizer, Moderna, and now the Johnson & Johnson vaccine, which is an adenovirus vectored vaccine, which means it uses a weakened and essentially dead adenovirus that is not commonly infecting humans to deliver the instructions to our immune system to make antibodies against COVID. It is not a live virus vaccine. That's another commonly asked question. None of the currently approved vaccines are live, so they're safe for patients with immunosuppression. And I mainly show this slide to highlight the vaccine efficacy that has been reported for the Johnson & Johnson Janssen vaccine, because I think you all have probably wondered this or come across people who have wondered this about the vaccine efficacy numbers that were reported for Johnson & Johnson. If you just look at the numbers, they seem not as great as the Pfizer and Moderna numbers. And some patients wonder if this is an inferior vaccine or if they should wait or ask for the mRNA vaccines instead of J&J. And I highlight this slide to show that the vaccine efficacy for all of these vaccines is wonderful. And I'll say this many times this evening, that we strongly recommend against picking and choosing or waiting for a vaccine. We think they're all excellent, and we want everyone vaccinated as soon as possible, and to get whatever vaccine is offered to you as soon as possible. The reasons that the overall US efficacy for Johnson & Johnson reported numbers is a bit lower is several reasons that I'll just quickly review because I think it's really important. These studies for the mRNA vaccines were done in July of last year. That's almost a year ago, and COVID-19 is very different now. There are variants, there are a lot of different things going on. And these two studies actually defined moderate and severe disease a little bit differently. So different studies, different technology, different definitions of severe and moderate disease, and they're really not comparable. And these numbers are excellent. And the most important thing is down at the bottom of the slide here, that the Johnson & Johnson efficacy against preventing hospitalization and death from COVID was 100%. So that sounds pretty good to me. And that's the most important thing. So all of these vaccines are excellent. We don't think one is better than the other, and we recommend you get whichever is offered to you. The nice thing about Johnson & Johnson's is 1 dose, and the mRNA vaccines are 2 doses. We, as I said, got these wonderful questions that are really excellent questions, and I just wanted to put them on a couple slides so I wouldn't forget to answer them before our Q&A. I think these first are a couple of questions of my own, and these are very nicely outlined on the CDC website. Again, if you have further questions or want to read more about this, their website's really up to date and helpful. But what if you already had COVID? Should you still get vaccinated? You should still get vaccinated. You absolutely should. And it's in fact a good thing. The CDC recommends, and you probably have read somewhere, that it's okay to wait up to 90 days after being infected with COVID-19, because you probably have some natural immunity that probably was better if you actually had symptoms or was sick, but it has been shown to disappear within 90 days or more. So while it's recommended you could wait till 90 days or later, you don't have to. There's no safety concerns there. You can get vaccinated anytime after you have COVID. And the important reason to still get vaccinated after you have COVID is we don't know how much or how long the immunity from a natural infection lasts. And if you didn't have any symptoms or had really mild symptoms, you might not have any immunity. So vaccine is important, even if you had COVID. What if you were exposed to COVID or got COVID between your first and second mRNA dose? Even in that situation, it's still recommended to complete that vaccine series. Of course, waiting A, until you feel better, and B, until your quarantine period is up, till you go out and get that second vaccine. But this is a good question, and this is important. What about COVID-19 in pregnancy or breastfeeding? Similar to patients with autoimmune diseases like Sjogren's, patients who are pregnant or breastfeeding are excluded from vaccine clinical trials. This is not unique to the COVID vaccine clinical trials. This is all vaccine clinical trials. And while they were not included in the studies, COVID vaccine is recommended by CDC and these other societies for maternal fetal medicine, and American College of Obstetrics and Gynecology is recommended to be offered to pregnant and lactating women. And in fact, we know that pregnant women who are infected with COVID have a higher risk of severe disease, hospitalization, intubation, death, and poor pregnancy outcomes. And we have no known negative effects of vaccines in COVID vaccines in pregnant or breastfeeding women. So the benefits are thought to strongly outweigh the risks. Many people also ask about impact of COVID-19 on fertility. And there are no data to show that impacts fertility in patients who are of childbearing age or men who are going to get vaccinated. These are some other great questions that we received. I'm just going to breeze through them. Is any one of the currently available COVID vaccines recommended more than another for Sjogren's patients? I think I already answered this, and that the short answer is no. We want you to get any vaccine that's offered to you as soon as possible. Does the vaccine prevent or just lessen the symptoms of COVID if contracted, or both? And that's a really good question too. Not all of the currently approved studies or currently approved vaccines reported data on this in their phase 3 trials. I think it was Johnson & Johnson and Moderna who did, that there was decreased spread of asymptomatic COVID as well as symptomatic COVID. So the important thing to remember, which I'll highlight a little bit later, is that they're not 100% effective, and certainly it would be unlucky, but you could get COVID if you were still vaccinated. And that's why it's important to be safe and continue to practice masking, et cetera. But at present, they're very effective at preventing any symptomatic COVID. The question, still is out there is, do they prevent asymptomatic COVID? And most of them, it seems like it does, but the most important numbers are that it prevents COVID of any kind. How are the vaccines performing in the real world, not just data from clinical trials? That's an excellent question. And so far, there are many data and reports to suggest that they're performing excellently. There are a lot of studies out of Israel in particular who has schooled us in vaccinating their population, and as well as reports from healthcare workers and other settings here in the United States that these are performing as expected, no surprises, and really cutting numbers of cases in vaccinated versus unvaccinated patients in the real world beyond the clinical trials I mentioned. Once vaccinated, is it still recommended to use caution? And for now, it is. A lot of patients come to me and say, if I still have to wear a mask, why should I get vaccinated? And the reason we have to do this now is we really need everyone, or as many people possible, to be vaccinated so that the infection is not still circulating in the community. You know, no vaccine is 100% effective, and we need to be safe and wear masks and social distance until enough people are vaccinated that this isn't circulating in the community. And with the variants that I'll talk about in a minute, that, you know, is a concern. So while you can feel more comfortable that you aren't going to get COVID and to be indoors without masks with other people who have been vaccinated, we still strongly urge you to be smart and safe, especially when you're out in public and indoors with other people who, you know, aren't vaccinated. Does having Sjogren's or other autoimmune diseases make you more or less susceptible to vaccine side effects? That's a really great question. We don't have any data to suggest that it does make you more susceptible or less susceptible to vaccine side effects. So far, the only information we have, which is interesting from the large phase 3 trials of the vaccines, is that older patients, which they have defined as 55 and older, have a higher incidence of that reactogenicity than, or I apologize, younger people less than 55 have a higher incidence of reactogenicity than people over 55. And again, that reactogenicity is not something bad. It's expected and indicative of your immune system doing its job. But otherwise, there are no comorbidities, either rheumatologic or not, that predispose you to having more side effects than someone who doesn't have that diagnosis. And that's a really good question. An interesting question was, are the Moderna and Pfizer vaccines rewriting the information in the nucleus of our cells? That sounds scary. And I could see how, if you heard or read or were told that is interesting to think about and sounds a little scary. So that's not what is happening. All vaccine platforms work to deliver instructions to our immune system so that our immune system can make antibodies against whatever instructions were delivered. So the mRNA is delivering those instructions to our immune system. And once it is inside and our immune system cells have received that information, that mRNA is destroyed within a day of you getting the vaccine. So nothing goes into the nucleus, nothing is integrated that is from the vaccine into our immune system. It's just this knowledge that has learned from these instructions it received, and then it is destroyed. So it's not altering your genome in any way. Unanswered questions. These were other questions asked that I don't yet have a wonderful answer for you, but we're hope to soon know about this. How long does the vaccine offer protection against COVID? This we do not yet know the answer to. We hope it's a while. We hope it's at least a year. And at present now, just from when the trials began, we at least know it's 9 months, if not more. But we'll need more time to know what exactly the duration is. Will we need a booster shot? Will this become a yearly vaccine? These are questions that we don't have the answers yet, but should soon, and they're really great questions. What is the efficacy of COVID vaccines in patients with immune-mediated diseases on immunosuppressive therapy? This kind of was a highlight of all the other questions, and I'm going to segue into the rest of my slides to help answer them. I had the fortune to sit on the American College of Rheumatology COVID-19 vaccine task force with about 12 other people, including rheumatologists, pediatric rheumatologists, and infectious disease specialists, led by Jeff Curtis at University of Alabama in Birmingham. We were tasked with reviewing all the data that are out there, appreciating that no COVID vaccine studies include patients with rheumatic diseases or Sjogren's. Also looking at all prior data, how other vaccines operate in patients with Sjogren's and other rheumatic diseases, and coming up with pertinent questions and voting on the answers of what our guidance should be about patients with rheumatic diseases getting COVID-19. We considered all types of therapies and treatment and how it might affect vaccine. The overarching principle from our guidance document, which was published about 3 weeks ago, and now our manuscript was published in arthritis and rheumatology last week, goes over our thoughts and all the data on this. So the overarching principle is that patients with rheumatic diseases like Sjogren's should get vaccinated. Rheumatologists should be at the forefront of advocating for our patients to get vaccinated. In terms of immunosuppressive therapy effect on COVID vaccine efficacy, there are no data on this yet. And so we extrapolated from what we know about other vaccines and appreciated that we need to learn more about this, and that there are many studies ongoing now, including one at my institution that I'm working on, looking at vaccine effectiveness in patients with rheumatic diseases. So everyone asked about hydroxychloroquine. I featured this as a highlight, that continue hydroxychloroquine throughout COVID-19 vaccine. We have a lot of data on Plaquenil, hydroxychloroquine, and other vaccines that we know a lot about, flu, pneumonia, et cetera. And it has no known effect on the efficacy of any vaccine. So we extrapolating to this, I think it's perfectly fine to continue. 2 points to discuss. Patients with Sjogren's, rheumatoid arthritis, are commonly on methotrexate, potentially could be on rituximab. Methotrexate does have potential to reduce the effect of vaccines. And we know this from a great study that was presented at our American College of Rheumatology meeting 3 years ago now by my friend and colleague, Kevin Winthrop, that shows that methotrexate reduces flu vaccine efficacy, seasonal flu vaccine. And they did a study to show that if you hold methotrexate after your flu vaccine, and that study, it was for 2 doses, it significantly increases the effectiveness of the flu vaccine. So while we do not know if holding methotrexate after any of the COVID vaccines increases efficacy, we think that it could, and that since COVID is a fatal pandemic disease, that this guidance should serve as a shared informed decision-making discussion between patient and provider, that if you're doing well from your underlying rheumatic disease and you feel comfortable holding your methotrexate for 1 dose after each of your mRNA vaccines or after one of the J&J vaccines, then that might be something worth considering doing because of the risk-benefit ratio. It's not right for everyone. It's not right for, someone who's on poorly controlled disease or on methotrexate for, end organ damage, but it's worthy of discussion. And we think it's worthy to let patients know that we think it could potentially increase vaccine effectiveness. So that is a recommendation. And then rituximab, we know very well that rituximab knocks down vaccine effectiveness of any vaccine. If you get a vaccine some months after a rituximab infusion, it's not going to work very well. So while this is difficult and challenging, especially with the 2-dose COVID mRNA vaccines, waiting as long after a rituximab infusion before giving a COVID vaccine is recommended if possible. And again, this is not right for everyone. This is challenging, not always possible, but when possible, this is ideal. A lot of questions about the variants. This sounds scary. What is this? So they're a little scary, but to start, viruses mutate. So this is not unexpected. This is something that SARS-CoV-2, or the virus that causes COVID-19, is going to do. And fortunately, the type of virus that that causes COVID-19 is very different from the influenza, and actually does not mutate, not nearly as much as influenza. We have our different flu shot every year. Sometimes it works better than others, but we're thankful that SARS-CoV-2 is not influenza because it's not mutating nearly as fast. So this is expected. There are what are now being called by the CDC variants of concern, which means they have potential to be more infectious or spread more quickly. And in the news or the paper, you've probably read about the top 3, the UK variant, the South African variant, and the P1 Brazil and Japanese variant. So these are out there. They're circulating in the United States, not nearly as much as they are elsewhere, but they do have potential to spread more quickly and potentially are associated with higher mortality. What we are still learning is how widely they have spread. Now, many places, effort has been made to sequence positive COVID tests to see how far spread this is. And CDC has a very nice map outlining the variants and how many cases have been reported in each state in the United States. We're also still learning how the disease caused by the variants differs from disease caused by other circulating variants, and also how these variants might affect existing COVID treatments, vaccines, and testing methods. So as I said, there are great efforts underway from the CDC and elsewhere to figure this out. Are they more contagious? Is the disease more severe? Do our traditional COVID tests detect these variants, or might they be false negative? And what is their response to treatment and the vaccine? And I can say that the nice thing about the mRNA vaccines is relative to other vaccine technologies, it's actually rather simple relatively to make an mRNA vaccine. They kind of just plug and chug the genetic instructions. So Moderna is already underway making a booster against the South African variant. And they have said they feel, and Pfizer as well, that this would be something relatively simple for them to make boosters against these variants. So that's important. So the key messages are that data suggests some variants might have increased transmissibility or infectiousness, increased disease severity, and might evade immune responses from a vaccine, and they are spreading globally. But the most important thing is that current mitigation strategies work. And this is probably the other main reason why we want everyone vaccinated so quickly before more people get sick, more people get these variants that, have potential to have vaccines might have decreased efficacy. So the more people are vaccinated while everyone continues to mask and social distance and be smart, that's the best case scenario. And that highlights the importance of vaccination. I think I have 2 more slides, and this last slide highlights, what we know and more about what we don't know about, does COVID vaccine cause or trigger autoimmune diseases? Could it flare Sjogren's? Could it cause new Sjogren's? Could it cause autoimmune disease? And these are just snippets of reports over the past year. Here's a case report of someone who maybe developed rheumatoid arthritis after one of the COVID vaccines, and Guillain-Barré, and did this trigger lupus? And these are many, many case reports. And the short answer is that we at present don't have a lot of data to suggest that the vaccines, we have no data to suggest that the vaccines cause autoimmune disease, but there are these smattering of case reports that COVID infection can trigger weird autoimmune things. And this is something we're learning a lot more about. And I had the fortune to publish this paper with my dad and our friend, Nikki Winchester, a wonderful medical student at our Cleveland Clinic Lerner College of Medicine, about what we know about COVID-19 and autoimmunity. And we kind of summarized it in this nice figure that we derived with the virus in the middle, and in the left, patients with pre-existing autoimmune diseases like Sjogren's getting COVID. And then on the right, patients developing new autoimmune diseases from COVID. And there's much we have learned here. There are reports of autoantibodies being detected after a COVID infection. This multi-system inflammatory syndrome of adults has an autoimmune flavor. These countless long COVID or post-COVID patients who we are learning and trying to figure out if this has any autoimmune etiology, but we don't know yet. So the clinical course of COVID-19 may be influenced by the immunologic milieu and immune-based therapies in patients with pre-existing autoimmune diseases who are infected. And as shown here, the infection itself could influence the clinical course of patients with autoimmune disease. Again, we have really not seen this pan out, but it's a theoretical, interesting thought. Or the development of autoimmune lab phenomena, like patients with COVID popping up with a positive ANA or a positive, lupus anticoagulant antibody or other autoimmune antibodies or new autoimmune disease. So this is something we are learning about, something that many, many studies are ongoing, both at the Cleveland Clinic, my institution, and across the board. What I can tell you is that COVID vaccines and triggering autoimmune disease, while a lot of patients are scared about that, we really have no safety concerns in that sense. And I always like to tell patients that vaccines have been around for a really long time, many, many decades, and there are no strong data to suggest that any vaccine triggers autoimmune disease or flares autoimmune disease or causes new autoimmune disease. And we have great faith in these vaccines and feel that they're very safe for autoimmune disease patients. So these post-COVID symptoms, we don't know if they're autoimmune. We don't know what causes them. We don't know if Sjogren's patients are more susceptible to these post-COVID symptoms. And as I said, many studies are currently ongoing to look at all of this. Key take-home points from my slides are that Can't say enough, COVID vaccines are safe, including for Sjogren's, and we recommend all patients with immune-mediated diseases, including Sjogren's, be vaccinated with any COVID vaccine that's available to them. And of course, continue to be safe with hand washing, masking, and social distancing, especially when out in public. These are wonderful resources I mentioned. Please follow me on Twitter. I like to share lots of information and what we're doing and highlight important things I've read, and please reach out with any questions. I always love an opportunity to talk to someone about vaccines. Thank you so much for having me. I look forward to the rest of your questions.
Well, thank you so much, Dr. Calabrese. You covered a lot of ground and answered the most common questions that we received at the foundation before your talk. So I appreciate your getting to so many of them, and we have more. So,
I'm ready.
The first question is, if someone has already had COVID, and let's say they had a mild disease experience, would they have a similar disease course if contracted again? And of course, I know you mentioned variants and there's some unknowns, but
that's a really good question, with the variants being a big unknown at present. But we like to think, and data have shown so far, that getting infected with COVID a second time is relatively uncommon, but certainly is possible. And there are many reports and series of patients who have been infected a second time, even a third time. And the clinical phenotype is kind of all over the place, including patients who were not so sick with their first course and were more sick the second time, and vice versa, or who even had an asymptomatic course the second time. So it's really unclear, and I can't give you a great answer to that question other than that both of those things have been reported, and I think overall highlights the need to get vaccinated even if you had COVID a first time.
Yeah, and kind of related to that, if someone's getting the vaccination and say they've had a mild or severe reaction to the first vaccination, does that predict what kind of reaction they'll have to the second vaccination?
That's a really good question. I think the short answer is no. What we do know is that with the 2-dose vaccines, both mRNA vaccines, the clinical trials have shown, that included each company over 30,000 patients, and now 100 million people in the United States who have been vaccinated. In general, the reactogenicity of the side effects are worse after the second vaccine. Most patients feel little to nothing after the first vaccine and more reactogenicity after the second vaccine, and not vice versa. An exception is if you have had COVID recently, that in a way acts as your first vaccine, and then you get the first actual vaccine and might have a more systemic reactogenicity similar to a non-infected previously person getting their second vaccine. So that's the way it usually goes. And I hope that makes sense.
Yes, it does. Thank you. For someone who's previously had COVID, can therapies they're typically taken by Sjogren's patients, such as DMARDs or a biologic, such as rituximab, can those reactivate a COVID-19 infection?
Great question. No one's ever actually asked me that. So I think what they're asking is if you had COVID and recovered and were on one of those medicines, could it, I don't know, make you have a prolonged course or make the infection come back? And the answer is no. What we do know is that patients who are immunocompromised, and a lot of this data comes from like solid organ transplant patients who generally are more immunocompromised than our rheumatic disease patients. But we do know that in particular with influenza, immunocompromised patients, especially patients on steroids, just shed virus for a longer time. So they could potentially make your, for example, like PCR COVID test be positive for longer than it otherwise would be, but it would not cause the infection to come back once it went away. But that's an interesting point, having early on, we checked a second COVID test to make sure you were better. And we very quickly stopped doing that because we learned that sometimes that test stays positive for a long time. And now we know even longer in patients who are immunocompromised. And that doesn't even mean that you're still sick. That test picks up virus that is dead as well as alive. So even after you're better, that test can still be positive and not mean that you're sick. So in that way, your treatments could make your test be positive longer, but it would not cause your infection to come back or reactivate.
Okay. Is there anything a patient can do to reduce side effects from the vaccinations? For example, the person who posed this said they had heard conflicting information on whether Tylenol has any impact on the vaccine. So is it okay to take that if you're having side effects? And also, what about prescription NSAIDs or non-steroidal anti-inflammatory drugs?
I'm so glad someone asked this. I should have included in my slide because this is really frequently asked question. And there's a lot of different things you might hear. And the short answer is that it's absolutely okay to take a fever reducer for any discomfort you feel after the vaccine. And Tylenol works very well, I can say from my own personal experience. What has caused uncertainty are studies, older studies, one pivotal study in infants showing that preemptive fever reducers, Tylenol, ibuprofen, at the same time as a vaccine, like before you develop any discomfort, aching arm, chills, potentially could reduce vaccine response in infants. So that is prophylactic Tylenol or NSAID. So for that reason, that data is not great. We counsel against taking Tylenol or an NSAID like right when you get your vaccine to prevent, like if I take this now, maybe I'll feel great. Don't do that. But if you have a sore arm, if you have a fever, if you have chills, take the Tylenol, take the ibuprofen. That's perfectly fine.
Okay, great. I'm sure a lot of people will be happy to know that.
It's a good question. Yes, please take it. It helps a lot.
So why do some people experience flu-like or other symptoms for about 24 hours and then those symptoms just stop abruptly?
That's a great question. I'm not sure I have a great answer to that, but from personal experience, I can tell you they do. After 2 days, it was if I said, what vaccine? I don't even remember. I felt 100% fine, but they are very fleeting. And it's, I think, related to that robust initial immune response from that, those instructions being delivered into your muscle cells in your arm. But that's, your immune system receiving those instructions and ramping up production, and then, cools down and creates immune memory. And that's why vaccines are great, and no vaccine should, ever trigger a persistent symptoms or chronic symptoms. And it's all very transient. And that's the beauty of it.
Okay. Next question was, if someone is having a Sjogren's flare or their symptoms are not, under control, is the vaccine still recommended? And would the vaccine increase the risk of worsening a flare-up?
Wonderful question. We actually addressed this in our American College of Rheumatology guidance document, what to do if patient is having active rheumatic disease. Whether it be Sjogren's or lupus, whether patients at home dealing with a flare, or even we had a special guidance recommendations for patients who are in the hospital being managed for a flare with severe end organ involvement. And based on what we know from other vaccines and the importance of seizing the opportunity to get your COVID vaccine when it's offered to you, we did not feel that any degree of rheumatic disease flare, including Sjogren's, should prevent you from getting that vaccine when it's offered to you. And we have no reason to think that getting that vaccine would worsen your flare or trigger a new flare or anything like that.
Okay. Are there other vaccine candidates that might get approved that Sjogren's patients should try to get, or should they be wary of?
I will say that whenever a vaccine is authorized, as our currently available 3 are, that means that it should be considered and you should get it if it's offered to you. We trust in the data, and we trust in the, data and safety monitoring committees. So if it's authorized, we want you to get it. At present, we have no reason for you to pick and choose one or the other, feel that one's safer for you or the other. The AstraZeneca vaccine is coming down the pipeline in the United States. There seems to be some hiccups with it getting approved if you follow the news, which is really kind of goofy if you've read anything about it. But this is a vaccine that's currently authorized in the rest of the world. They presented their data to, you know, our powers that be here, and they had some questions, and it's all, I don't quite fully grasp it, but I think it's going to be okay. And that probably will be approved in the coming weeks as well. And that's going to be another great candidate as well. That is similar vaccine technology to the J&J vaccine, but will be 2 doses given at least 4 weeks apart, and is also an adenovirus vectored vaccine, a non-live vaccine. So another great option. We say the more, the merrier.
And speaking of the more, the merrier, someone asked, should they receive different variants of the vaccine? I don't know if they would actually have access to that.
Sure. I see how this could, I don't know.
More protective.
Yeah, this is something interesting, and that the CDC actually addressed in their, you know, guidance document about frequently asked questions. And of course, it's not recommended to mix and match COVID vaccines. If you get, you know, your first shot, the Moderna, you should get your second shot, the Moderna, and vice versa with the Pfizer. And more is not better in this situation. We have the vaccines on their own are very effective, and we have no data on the safety or effectiveness of giving one after the other, or swapping one for the other. The CDC actually did say that if you got your first dose, the Moderna, and for whatever reason you could not get your second dose as the Moderna, and your second dose had to be the Pfizer, that wouldn't be the end of the world, but they don't recommend it if it's not necessary.
Okay, and someone wanted to know if the vaccines contain heavy metal or other adjuvants, and if you have any guidance to someone who might have food and environmental allergies. Any of those weigh in when you're selecting a vaccination or determining whether to get
really great question. I probably should have put a slide on that as well. It seems almost a long time ago now, but it probably was last month with all the last month or two with the reports of anaphylaxis when the Pfizer vaccine was first authorized, and then the Moderna. We've now learned that the incidence of anaphylaxis after either of those vaccines is very low, per 2 million. And their CDC has come up with guidelines given the experience, given the vaccine contents, and what we've learned so far about contraindications to getting vaccines from an allergy standpoint. And patients ask about this a lot. So the only absolute contraindications to getting the vaccines are if you had an allergic reaction, severe and immediate, to the first dose of the vaccine, or if you had a severe allergic reaction to a known component of the vaccine. And these are widely accessible and available on the CDC website. They list all the components of each of the vaccines. Patients then ask, what if I have anaphylaxis to shellfish, or what if I'm allergic to trees or cats? These are not contraindications to the COVID vaccine. There are scenarios where it would be recommended to maybe confer with like a board certified allergist, which would be if you had a anaphylaxis to a previous injectable medicine or previous vaccine and weren't sure if any of the components were the same in the COVID vaccine. That would be, you know, very reasonable to see an allergist about that. But any sort of environmental allergy, food allergy, these are not concerns with the vaccines. I forget what the first part of that question was.
Well, they were just asking if there were heavy metals.
Heavy metals. There are not any heavy metals in any of the vaccines. And the nicest thing is that if you go to the CDC website and Google, Google CDC COVID vaccines ingredients, it will pull up a list of everything. And these vaccines are not adjuvanted. Adjuvant is something that is attached to the vaccine that revs up your immune system, most commonly found in like the current shingles vaccine, Sjgrens, that's very adjuvanted with a novel adjuvant. There are adjuvanted COVID vaccines coming down the pipeline, one from Novavax, which I anticipate will be approved by the end of the year, that is adjuvanted, but the 3 currently authorized drugs are not adjuvanted.
Okay, and then a final question just to quickly wrap up. Some people have felt like getting the vaccination improved some of their Sjogren's symptoms. Is this possible? And also, can you just say a few words about what we might learn from COVID that could be helpful to diseases like Sjogren's? Will this lead to some better answers for us?
That's a really wonderful question. For the first part, that's really interesting. And I can't tell you if that's true or if it is, why that might be, but I can say that anything is possible at this point. And what we're most interested in right now, in terms of long COVID, these patients, long haulers, post-COVID, what we now call post-acute COVID syndrome, PASC, is that a lot of patients with post-COVID feel better after they get their COVID vaccine. This is something very new and weird that we're very interested in to understand, and makes no sense to us. So I don't know the answer to that question. That's very interesting, and I'd love to hear more about that. What can COVID teach us? COVID has taught us a lot and will teach us a lot more. I think in grand schemes, it's taught us a lot about the immune system and taught us a lot about the effect of immunosuppression and underlying disease. And it's probably taught us more about what we don't know about our immune system and the response to, this virus. Coronaviruses have been around forever, and how is this virus so weird and new and different, and we can't understand it, with a perfect example being, lots of rheumatic disease treatments have been in many, many clinical trials to treat COVID, with a drug called tocilizumab or Actemra being from the get-go a really prime candidate. We use this in rheumatoid arthritis and a bunch of other stuff. And you could flip a coin and land on a study that was positive, and then a study that was negative, and every week there's another one. And why can't we figure this out? What are we missing? And it has something to do with probably immune endotypes, what we call, where there's something missing beyond the risk factors that we've identified that makes people sick with COVID. Why can a 28-year-old with no comorbidities die from COVID and a 100-year-old be fine? We're missing something about the immune system, and we're trying really hard to learn about that. And I think it's opened the doors to technologies and treatment and collaboration, and has been really hopeful. And the vaccine story in particular has been really exciting and hopeful.
Yeah, well, I've learned a lot tonight, and I know that everyone has, so we really appreciate your taking the time. And just to speak to, I know there've been a lot of questions in the chat. We will take a look at these. We will be answering these, whether it's in our newsletter, Conquering Sjogren's, or other means. We will get to as many of these as we can. So thank you so much, Dr. Calabrese.
Thank you for having me. Thank you all.
Yeah, Janet.
Thank you. Oh, that was a fantastic presentation. I think you all agree. And as Kathy said, we are going to take a look at your questions, the additional questions, but you will also get an email, a follow-up email within the next couple of days with the link to this video, because many of the questions that I saw kind of flying by the chat, Dr. Calabrese did cover. It's just the presentation was so informative and so dense that it might take you a second time to go back and get some of your questions answered. So please take a look when you receive that email and with the video link. Also, a little tip, Dr. Calabrese did on her last slide give you her email for any of those really unique questions that you have. But again, we will be doing our best to answer your questions as well. It is our intent to keep you informed on COVID, on the vaccines, and on research that we are learning as time passes. And we just want everybody to be healthy, take care of yourself, and get the best information that you can to make the best choice for yourself. I am glad to see through our poll that 70% of people are already well on their vaccination journey, and 22% are just getting ready to start. So that is fantastic. And just real quickly before we say goodnight, I want to thank the Sjogrens Foundation team. You all know I'm new and I came in and decided we should do this program rather quickly. And Dr. Calabrese came on board quickly. Thank you so much. And our very own Kathy Hammett, who has been asking questions tonight. Matt Macara, who's behind the scenes, but he's director of our scientific and medical affairs. And then Basil, our VP of philanthropy, has really taken a team to put this together. And I think it's been an amazing program tonight. And so glad that you all could join us for this. We will be keeping that patient poll open, and you have the opportunity to go back in and alter your answers. We want to make this poll a little bit more present, so we'll be promoting it now that our webinar is over, and we'll be removing that question area. But just to keep tabs on how we're all doing as a whole community, I find it very helpful to know what I might experience on my second vaccine, and just seeing the group information makes me know that, you know, I'm probably going to be okay. So for my second vaccine as well, which I have coming up. So I certainly get a lot of solace knowing that our community sticks together, we talk together, and we can kind of take a look at information together. Even though it's informal, it's interesting. So I also want to highlight, before we say goodnight, that you should have gotten an email yesterday. Our National Patient Conference registration just opened yesterday. And you know that we will be doing our patient conference June 11th and June 12th. And I encourage you to go ahead and register early. Helps us plan and helps us get really excited as well. And the conference looks fantastic. It again is virtual this year, so everybody can join just like we did last year and like we're doing right now. So that is it for this evening. Again, Dr. Calabrese, thank you so much. Kathy, thank you. And everyone have a very, very good night and stay healthy. Good night.